I would like to thank the organizing committee, Dr. Rabokar, Dr. Kaustubh Patel, and rest of the organizing committee for the honor. My biggest disclosure is I am a medical oncologist. In this conference, I realize is very surgery based, so I hope you enjoy my talk and hopefully it's somewhat useful to you. I don't think this audience needs any introduction on thyroid cancer, but what I want to show from this slide as well as the next slide is that thyroid cancer is not one disease. It is a conglomerate of diseases where you have a low-risk thyroid cancer that is barely a cancer to something such as undifferentiated thyroid cancer or anaplastic thyroid cancer that remains highly lethal even today. This change or the differences in the character of these cancers is driven mainly by the MAP kinase output, which is brought upon by a variety of sequential mutations. For example, the more aggressive cancers are characterized by the TERT or P53 mutations along with PI3 kinase pathway. Fortunately, for majority of patients, mostly 90% or more, it is not a question about which systemic therapy to offer. Most of the time I struggle, and most of my medical oncology colleagues or endocrinology colleagues struggle with when to start the treatment. And that is characterized or by surgical pathology or the histotype of the cancer, location of the disease, growth pattern, and mutational profile and symptomatic burden, but it also depends on what the patient wants as well. There is patient input needed when you start a very aggressive treatment like a kinase inhibitor. So even though my talk was supposed to be on a state-of-the-art systemic therapy, I'm mainly going to talk about neoadjuvant treatment because this is what is going to be hopefully helpful to this audience. And I'm mainly going to present three trials that have been presented recently but not published yet. I would like to start with a case. This is a patient I saw almost a year ago, 73-year-old male who presented with syncope and had multiple PARS, and imaging including angiography showed this mass in the retropharynx, which was a transformed node from anaplastic thyroid cancer. So this was P53 positive on immunohistochemistry and PAX8 positive, but was negative for everything else including BRAF. And so this patient obviously needs a systemic therapy. He could not even stand up. Every time he would stand, his heart rate would go in 30s and low blood pressure. So we had to start him on systemic therapy. And this is a nascent field where we are starting something with the hope that we can probably operate on this thyroid cancer patient. So these were the three trials, dabrafenib, trametinib, and pembrolizumab in anaplastic thyroid cancer that was presented at the ASCO 2025 by Mark Zaffario. Then selpercatinib in RET mutated or RET altered thyroid cancer and lenvatinib at the American Thyroid Association meeting just a few days ago. There are many important issues to consider in neoadjuvant treatment, which is the patient selection for the possible surgery, the comorbidities that go with the patient, which therapy to choose, which requires most of the time a next generation sequencing panel, and then of course how to assess the treatment response both on imaging and more importantly on the pathology. There are some newer things to think about as well. Could we do circulating tumor cells or the tumor DNA in the blood that could guide us in deciding which adjuvant treatment or does the patient even need adjuvant treatment. And of course, a very important issue about intra-op or post-op surgical complications considering you are using very toxic treatments including VEGF inhibitors. Dave Shankar led this group in defining what is advanced thyroid cancer a few years ago, as well as defining who actually needs upfront mutational testing. And some of these questions are being now addressed as we go along, including how to assess surgical risk or how to assess the pathology. But all of these fields are nascent, and we still need some consensus. This is surgical assessment pre-op using the surgical morbidity score. This is the MD Anderson score, and I don't have to educate this audience on what the advanced thyroid cancer that involves the surgical complications, or what leads to the surgical complications in terms of vascular involvement or involvement of the fascia, things like that. So there are multiple scores, but in these trials, either this score was used or what is called as the triple M score, or the which is from MGH, Memorial, and the MSK people. It goes from 1 to 34. The treatment for the thyroid cancer has come a long way in last 10 years. When I was a fellow, we didn't have a single medication. We still used chemotherapy. But in last 10 years, we have multiple. And I have just put few agents here. There are, for example, in a BRAF mutated tumor, you have 3 sets of combinations that are available and FDA approved now. And similarly, the highly selective first generation RET inhibitors, including selpercatinib and pralsetinib, have changed the outlook for the RET altered tumors. ALK and NTRK are very rare, but when you see them and treat them with the specific inhibitors, the response is very satisfying to the physicians. Of course, more importantly, when you don't have any target, I think lenvatinib and immunotherapy are emerging as treatment options, and I think I'm going to show you a lenvatinib trial that Greg Randolph conducted. China is actually leading on this front, where they have multiple kinase inhibitors and newer PD-1 agents. They are doing some really good trials, but unfortunately those drugs are not available in the United States and we cannot use. But I'm actually very excited to see that data, because the numbers are very looking very good from those trials. Moving on to the actual studies, this is the DTP regimen used for anaplastic thyroid cancer in the neoadjuvant setting. This was a phase 2 study, single arm, led by Mark Zafferio and conducted at multiple centers all over the United States, considering the rarity of the anaplastic thyroid cancer, as well as I think his main motivation was to show that what they had learned previously from case reports at MD Anderson could be applied in a multi-institutional setting as well. This is the trial schema. As you can see, you initiate the treatment with dabrafenib and trametinib, and then you give this treatment for a cycle, and then once the patient's tolerance is assessed, you actually add the immunotherapy. And then if a patient has good response, you proceed to surgery. Following surgery, most of the patients will need radiation. Immunotherapy can be safely added with no issues, but the dabrafenib and trametinib are added following the adjuvant radiotherapy. And then immunotherapy was given for a total of 2 years, and if the patient was still alive, you would continue the dabrafenib and trametinib. The primary objective was the R0 and R1 resection rate, and they had a very low ball compared to the historical 5% of the patients who will undergo R0 or R1 resection in ATC. And the overall survival, which was the co-primary endpoint, was compared to the historical median of 9.6 months, which was, I think, very reasonable. There were multiple other key secondary endpoints, including objective response rate, and this is the waterfall plot. It shows you the response rate at about 72%, but you can see most patients actually had a tumor shrinkage. The R0, R1 resection rate was about 74%, and 2 patients additionally had surgery a little bit later. So in all, 31 out of 39 patients had surgery. This is the surgical morbidity score. It significantly decreased from 3.2 to about 1.7. I think this if done consistently across the trials, could be a great tool for us to know what is the complexity of the patient population enrolled, so we don't have a bias. The survival was, median survival was about 18 months and PFS was about 14 months. But if you look at patients who had complete response versus patients who did not have complete response in the pathology, the median overall survival was drastically different. It was not reached in the patients who had complete response, and it was about 12 months in the patients who had still had residual disease. And what is important to realize here is this is very unique to this trial, where you have a response. When we say complete response, all the anaplastic thyroid cancer is gone, but the PTC is still in the sample. It doesn't go away. It just stays. It's very stubborn. But it shows us the tool of assessing. And I think they are also doing some ctDNA and other genetic studies to see if we can characterize this population in a different way as well. In summary, I think dabrafenib, trametinib, and pembrolizumab I personally would consider as a new standard for any anaplastic thyroid cancer patient, whether we are planning a surgery or not, but certainly could be employed as a neoadjuvant treatment in stage 4B and even in 4C patients. Moving on to the RET-altered thyroid cancer, this agent has completely changed the outlook for MTC patients. These are rare populations, so I'm not going to spend too much time. This was, again, Mark Zafarios trial, but only at single center MD Anderson. Most of the patients were medullary thyroid cancer patients with a mutation, but they had a few patients which, from PTC with a fusion as well. The key eligibility criteria was T3, T4 tumor, large nodal burden, and patients with distal metastasis were allowed. The overall response rate was about 53%, but just like the ATC trial, almost every patient saw some shrinkage. The R0-R1 resection rate was about 90%, and the surgical morbidity score went down from 2.5 to 1.7. So I know we probably cannot compare across the trials because the investigators are different, who is assessing the score is different, but if you recall in the ATC trial, that score was about 3.2, and it is 2.5 here, suggesting maybe the ATC patients were much more advanced. Moving on to lenvatinib, this was presented by Greg Randolph at the same meeting a few days ago. This is lenvatinib in the neoadjuvant setting. So patients did not need to have a specific mutation. So every thyroid cancer patient could be eligible as long as they met the eligibility criteria. This was the schema of the trial. The locally advanced DTCs were enrolled. They received 2 cycles of lenvatinib, and if they had an adequate response, they proceeded to surgery. But if they did not, they were allowed to get 2 more cycles and then 2 more cycles. So in total 6 cycles if they needed. The key eligibility was anyone who the surgeon thought would be at risk for a R2 resection. And so there are some criteria that I'm not going to go into too much detail here, but any vascular involvement or the nerve at risk made them eligible. What is important is to probably focus on exclusion criteria. So if you had a complete carotid encasement or hemoptysis or had intraluminal tumor, they were not eligible. And again, the primary endpoint was R0-R1 resection, and what they described was at one of the target interfaces, and I hope I have that slide. So these were the target interfaces: the muscles, cartilage, esophageal involvement, RLN, and major vessels. They also assessed for safety as one of the key secondary endpoints. 28 patients were enrolled, majority were females, and about 82% were papillary thyroid cancers. And in all, almost 5 cycles were given on a median to the patients, and 82% of the patients underwent surgery, and 20 patients were able to have R0 or R1 resection, that is 71%. This is the waterfall plot. Again, partial response was 39%, so not as good as the previous 2 studies, but remember, this is mutationally agnostic population, so unselected for any mutation. And most importantly, there were no reported cases of fistula, significant bleeding, or delayed wound healing, which is important to realize that lenvatinib is a very powerful VEGF inhibitor. And they were looking at these specific issues because there were some trials, including at MD Anderson and in Germany, that have shown with lenvatinib there is significant risk of fistulas and bleeding in especially advanced cancers, including ATC. So in summary, I think neoadjuvant therapy is very reasonable in thyroid cancer. However, we need to select the patients very carefully, probably in the context of a tumor board where you have a good radiologist, surgeon colleagues, preferably more than one. And some people probably would ask for randomized evidence, but I don't think it would be very reasonable to do a trial like that, and will be a huge effort. What probably we need now is real world evidence where we are collecting cases in a more systematic fashion to show what these trials have done we can do reasonably in any practice. The patient selection probably depends a lot on comorbidities. For example, who has high blood pressure or cardiac issues when you're thinking about lenvatinib versus BRAF inhibitor therapy. Resectability in terms of surgical assessment, margins. The cutaneous oncology people are now doing response adapted surgeries and changing their margins from the pre-treatment margins. Could we do something like that in thyroid cancer? How long to hold the drugs before, after? And then of course the fibrosis and the treatment response and pathology we probably still need to sort out. And of course, countries like India and the rest of the world, including Africa, availability of the drug is a major thing, including even availability of the NGS testing. So going back to our case, that person was not able to get out of the hospital, so I gave him a cycle of chemotherapy. And guess what? The NGS actually showed BRAF mutation. So every time you have a immunohistochemistry that is negative doesn't mean that person also is going to have no mutation. So I think it's very reasonable to do NGS on everyone, including BRAF negative patients with immunohistochemistry. So he received dabrafenib trametinib for 2 months. He could not get immunotherapy because he had side effects, but he got good response. He underwent surgery and there was a complete pathologic response, and he received, we still gave him adjuvant treatment, but I think that should be the next area of research for all of us to figure out who can skip the adjuvant treatment versus who needs it. I'm going to end with this slide. I love the room names. This is Charlie Mayo. He's one of the founding members of Mayo Clinic, along with his brother William Mayo. Both of them were actually thyroid surgeons. And this is Will Mayo and this is Charlie Mayo. And he was instrumental in reducing mortality of the Graves surgery by using iodine preoperatively, and that was the idea of Henry Plummer, who was the Plummer-Vinson famous. And then the Mayo Clinic continues to have high standards in thyroid cancer surgery. This is Eric Moore, who's currently operating, and my colleague, and Mayo Clinic thrives on the motto of the needs of the patient come first. So I again thank you for listening, the organizing committee for the honor. I'm truly enjoying the meeting. Thank you.
Excuse me. So we showed the data of ATC, that is anaplastic thyroid cancer, and the patient who responded well in a pathological response they got the good survival. So, just I want to know that, is this a CTC in your current practice regarding the pathological response? So, do you do CTC?
We don't do CTC. I don't think there is a good assay. The assay that was designed and actually published is based on very old technology, so the sensitivity was terrible. I think the ctDNA assays are going to be better, but I am also going to be working with another basic scientist to actually go back to looking at CTCs in anaplastic thyroid cancer using the newer technologies, so more to come. But right now we are mainly relying on pathology. And I actually very rarely skip any adjuvant treatment. I keep going.
Time for question. Dr. Ashish, thank you so much. We had a similar such session yesterday. I wish you were there. Nevertheless, my question to you is in the context of locally advanced differentiated thyroid cancers. I presume you recommend doing NGS for all the cases. So my question
Correct,
is,
yeah.
in the context of locally advanced DTCs only, given the time, resource, availability constraints of NGS, would it be fine to use lenvatinib as a first-line treatment, at least until NGS reports come, or until such a period that we find that lenvatinib isn't working, at least in the context of Indian setting, given that lenvatinib has excellent action in DTCs?
I think it is reasonable, but I am assuming the restraint or the resource constraint is that person is never going to have an NGS. I think in that setting it is okay, but if you are eventually planning on getting an NGS, I think waiting for 2 weeks or 3 weeks or even 2 months in that setting, I don't think is prohibitive. But if you are never going to get NGS, I think it is reasonable to use a broad spectrum MKI. Having said that, I think the patient selection is very important. These are powerful VEGF inhibitors, so if you have intraluminal involvement, the risk of bleeding and fistula is high, and fistula almost always is fatal.
So quick follow-up to that question, did Professor Randolph's trial also include NGS for all the patients, because that was not specifically mentioned?
No.
No.
Yeah.
So when in anaplastics, when it's BRAF negative, how is your response rate?
That is an area of active research. So I personally use lenvatinib and pembrolizumab, and the response rate is somewhere around 40-50%, but it is not as satisfying as treatment with the DTP.
So, do you do PD-L1 and see the response of immunotherapy? Is there any practice?
You don't need PD-L1. I actually published this when I was a fellow. It was one of the first papers. Almost all anaplastic thyroid cancers highly express PD-L1. And so there is no need to test. I would probably give it to everyone. Having said that, you have a high PD-L1 score, and you would think this cancer also has a high tumor mutational burden. It doesn't. Yeah.
All right, thank you.
Thanks.